Welcome to this lecture on myocardial blood flow reserve and the evaluation of microvascular disease as it pertains to cardiac PET myocardial perfusion imaging. These are the objectives for this presentation. In this image here, you see the gross anatomy of the coronary arteries and the microvasculature of the heart. You'll notice that you do see these larger vessels, the epicardial vessels that we typically know about and talk about with stress testing. You have the left main, the left anterior descending, the right coronary artery, and the left circumflex. However, when you actually look at the vasculature in the heart, you see a lot of microvasculature. You see a lot of really small arteries and capillary beds and veins because the heart is a highly vascularized organ. And you also see that many of these blood vessels are very tortuous. Um, the heart is very, very well perfused organ. And the problem with traditional cardiovascular imaging, whether you're looking at even a heart cath or typical SPECT and PET imaging, is that you don't see the microvasculature. And a lot of people could have coronary artery disease, and it will show up in the small, tiny vessels, especially with calcium buildup and things like that, before it shows up in the larger epicardial vessels and actually creates an occlusion. So patients could have heart failure, they could have coronary artery disease, but because it's in this microvasculature, it goes undiagnosed. The only way to actually assess and diagnose for microvascular disease is with PET MPI imaging with myocardial blood flow evaluation. You can't see it with a heart cath, CT, any other diagnostic invasive or non-invasive testing will show microvascular disease other than cardiac PET MPI with myocardial blood flow reserve. The evaluation of myocardial blood flow reserve isn't a new protocol or a new test all on its own. It's just a different technique that you use to capture the flow when you're doing myocardial perfusion imaging with PET. So the difference is that you acquire enlist mode and you begin imaging the rubidium 82 as soon as it's injected so that you can watch the bolus arrive to the myocardium. That's really the only changes in protocol that you have are to acquire it in enlist mode, and then you begin your acquisition sooner so that you can actually see the arrival of rubidium. The processing is where it becomes a little bit more tricky and nuanced even to interpret that. But there will be a region of interest box in the center of the ventricle. You want to make sure that that box is centered in the ventricle, and then you evaluate the curve of the rubidium arriving to the myocardium, and you look for movement through the ventricle and then eventually accumulation into the myocardium. So this is an example of a study that was done with myocardial blood flow reserve. I know this is a bit blurry and I apologize for that, but I wanted to make it sure it was big enough for you to see. In the top left-hand corner here, you see the regions of interest that are drawn around the myocardium, and you'll notice that the region of interest and what you see that is actually the myocardium is showing up as purple, whereas the hottest activity is actually inside the ventricle, and that's because you're capturing that first pass through the heart. You're capturing that bolus as it's going through the heart and then being taken up by the myocardium. So the images that you see here are as it's making that first pass through the ventricle. You do end up getting a polar map with those, and that will tell you regionally where there is a decrease in myocardial blood flow reserve. On the right side of the image, you see the time activity curve. and it's color coded here. The left ventricle is green at rest and stress. The right ventricle is blue at rest and stress. And then you also see the global ischemia, or the global blood flow. So as you see right here, you will see the green and the blue arriving to the myocardium. And then you see the sharp decrease. This is as it's passing through the ventricle, it will peak and then it will decrease in the blood pooling and the vasculature, and it should slowly increase in the myocardium. So you should see this curve slightly increase as it's being accumulated into the myocardium. Now, if you go down to the global results, there's a lot of numbers here. What people typically look at is this third column over, or the last three actually. So the third column over is the blood flow reserve at stress. The fourth column is the blood flow reserve at rest. And then the reserve number here in the last column is that ratio. That's the myocardial blood flow reserve ratio that tells you how much of it is there. You should see a rise in blood flow between rest and stress because you should have a dilation of the blood vessels. And typically anything above 2 is normal. We want that to be higher in number than what it is. This image is showing you coronary artery disease versus microvascular disease. With coronary artery disease, you have either an open artery, some plaque buildup, or hardened artery. Typically, when plaque starts to build up, you can start to see that calcification on calcium score or CT. And then if it gets enough plaque buildup, you start to see it affecting the perfusion on CTAs or perfusion studies with either SPECT or PET. And then once it gets hardened enough and completely blocks that blood flow, this is when patients would maybe need a bypass if they didn't have collateral circulation. Typically, at the point that it becomes hardened, there's not much intervention that can be done. It's more to be medically managed unless they can do a bypass. Once there's plaque buildup, they can do a stent. Typically, they won't do a stent until it's about 70% or so occluded. Some will go as low as 50%, but usually they won't even intervene till it's closer to 70 or 80. With microvascular disease, you either have an opened microvessel or a constricted one. Constricted one greatly reduces the amount of blood flow that actually reaches the capillaries and the actually will get into the myocardium. This diagram is showing you macro versus micro circulation. Macro circulation is what we are more used to seeing with perfusion imaging. You have the left main, the left anterior descending, the right coronary artery, and the left circumflex, and those are the major blood vessels. These are transport vessels that are responsible for transporting the blood into the microcirculation. In the microcirculation, you have the small arteries, the arterioles, and the capillaries. They Small arteries and arterioles have a role to transport, but also to regulate the flow. And then in the capillaries is where the exchange occurs. But when you have microvascular disease or you have a disruptance in the micro vessels, this has a great impact on the ability for the blood to actually get into the myocardium and for that oxygen exchange to occur. So this is where if there is blockages here or the presence of microvascular disease, it leads to inflammation and chronic inflammation in the myocardium, microvascular rarefaction, endothelial dysfunction, arteriosclerosis, coronary spasms, and diffuse fibrosis will occur. I realize that microvascular rarefaction might be a new term. If that is a new term for you, that is the loss of capillaries and arterioles in microcirculation. It doesn't just happen within the heart, it can happen in the brain or other organs as well, but it is a hallmark of chronic disease, and it is also a hallmark of hypertension when it happens in the microvasculature of the heart. So microvascular disease is also known as small vessel disease. It can be abbreviated as SVD or MVCD. Risk factors include being female, diabetic, or having underlying inflammatory disorders. Peripheral vascular disease is another contributing risk factor. And it is essentially just heart disease that affects the walls and inner lining of the tiny coronary artery blood vessels that branch off from the larger coronary arteries. Small arteries are damaged, they don't dilate properly, and then they can reduce the blood flow to the heart. Microvascular disease is very predictive of heart injury or death from cardiac issues, and it's predictive of coronary artery spasms, myocardial infarction, heart failure, and even death. It cannot be detected except with cardiac PET CT MPI with myocardial blood flow reserve. The heart catheterization is too big to reach the micro vasculature. CT, MRI, even regular MPI imaging, the spatial resolution and everything like that is a little bit too not not good enough to see the effects of microvascular disease, and it would have to be pretty severe to into the epicardial vessels to be seen on other imaging. So it is very important to find microvascular disease and manage those patients, but it is impossible to diagnose without myocardial blood flow reserve. So this is showing you that both epicardial and microvascular abnormalities. Primary reason for blood flow is that missed epicardial coronary artery disease, but you can identify the microvascular coronary artery disease. So this is kind of showing you the epicardial arteries are greater than 400 micrometers in diameter, but all the way down to the capillary beds, which are about 10 to 20 micrometers, sometimes a little smaller. And these are the exchange vessels. So you'll notice that the total resistance and function greatly decreases as there is issues or metabolic flow distribution problems within the smaller vessels. This image shows a couple of the things that are important to look at when doing myocardial blood flow reserve. So in the center picture here where you see the red circles, that shows the proper positioning of the region of interest. It needs to be on the left atrium. That way you can catch the arrival of the bolus of rubidium as it starts to go through the left side of the heart, and you will capture the bolus going through the left part or the left ventricle. And you do that on rest and stress. And then you'll look at the time activity curves to make sure there's no technical problems. The curve should have a nice peak and then decrease down and then slowly rise back up as the activity is concentrated in the myocardium. That initial peak is the blood flow and the rubidium passing through the left ventricle. And so then you see that valley again as it leaves the left ventricle, and then you should see it slowly rise back up as it concentrates in the myocardium. So if you see that it is a more rounded, spread out curve, then maybe there wasn't a good bolus or the patient had their arm bent. There was maybe a problem with the IV where it wasn't a good bolus through the heart. That will disrupt the blood flow reserve numbers. And sometimes you will see a spike or several spikes in the curve. If you see any spikes in the curve, then that's also shows that there may be some technical difficulties. Sometimes patient could have a resting blood pressure or resting um, pressure product that is too high, and that will disrupt the blood flow and skew these blood flow numbers. But it's important to look at that chart or the time activity curve there and make sure that you have a nice good spike of the bolus followed by increase in the myocardium. If you're seeing that it's kind of staying high, it goes high and it stays high and kind of levels off, that will happen sometimes with people that have heart failure, cardiomyopathy, and have a decreased ejection fraction, especially if it's really low, because it spikes as it goes through the heart, but then it stays in the blood pooling and it's not actually getting into the myocardium. So that's one of the ways that that will present. And then if you look over here on the left and you look at the actual blood flow reserve numbers, this is normal stress and rest. Rest should be about less than 1 or less than 1.2. Stress should be above 2. The overall ratio should be 2 or higher. And mostly what we look at first is this global number. If the global number is less than 2, then you'll start looking at was the rate, was the resting numbers too high? If they were, that will skew it. And then that would kind of usually point to a technical difficulty. And then you'll want to look at this individual stress vessels and the individual ratios for different vessels, like the LAD, for example. In this one, the RCA is a little bit lower. This is still normal because it's greater than 2. But let's say that that came back as 1.7 or something. Then that points to a problem specifically with the RCA, but the rest of the vessels are okay. So those are how you look at the numbers. Always start down here with the global reserve numbers and individual vessels and take it from there. This is the categories of myocardial blood flow reserve and general interpretation and classification of risk in relation to global myocardial blood flow reserve. If it is greater than 2, that tells us that the interpretation is normal, and that carries a very predictive value of coronary artery risk that says it is low. Those are the patients that, 98% chance that they have no heart disease or cardiac events in the next 5 years. So if the blood flow reserve is greater than 2, that's normal, and that has a very low risk of coronary artery disease. If it is 1.7 to 2, that's considered mildly abnormal and the patient is at intermediate risk. At that point, it would be advisable to look at the perfusion as well and decide whether or not to cath that patient. It's also advisable to look at the individual arteries to see if one of them is significantly lower than the rest, and that would point to a need probably to send them to the cath lab because they probably have single vessel disease. If it's globally low, then that could be indicative of multivessel disease or global ischemia. If it's 1.2 to 1.69, same thing as I just said, but the risk is very high. So look at all those individual vessels, see if there's any single vessel that's really low, or if the patient may have multivessel disease, especially in the presence of perfusion defects. That patient carries a very high risk of coronary artery disease, and they have a very high risk of having a cardiac event in the next 5 years. If it is less than 1.2 with a perfusion defect, this is considered highly abnormal, and the patient has a very high risk of coronary artery disease and carries a very high risk of having a cardiac event in the next 5 years or closer than that future. If it's less than 1.2 without a perfusion defect, you won't probably want to consider this a non-diagnostic study. This is an indeterminate coronary artery risk, and you cannot rely on that. If the patient has a perfusion defect, then that falls into the high risk category. But if they don't, then you want to look a little bit closer and see what their resting blood flow was, what their rate pressure product for their resting was, see what their resting blood pressure was, and also maybe reevaluate them to see if they had caffeine, because the person may have been what's considered a non-responder. And typically this happens when people don't follow the proper prep, or maybe they follow it, but for some reason the caffeine didn't clear out of their system within the allotted time frame. And so they did not vasodilate appropriately, and that will make your ratio be abnormally low without the presence of blood flow reserve. It's just an inaccurate result. These cutoffs are arbitrary. I do want to point with that. They will vary slightly between labs. You also need to look at the greater picture when a cardiologist is or physician is interpreting these, because patients that have advanced age may have a slightly decreased blood flow reserve, but don't really have a coronary artery disease risk. And that might be like 1.8 or 1.9 blood flow reserve. And that's because they just have advanced age. And, patient in their 80s maybe at 1.9, 1.8, something like that, when they're perfectly normal. So it's not clear cut. It's very important to get a very good history on patients and to look at all the data, or, all the majority of the data that's on the study. There are quite a few clinical situations where the myocardial blood flow reserve makes a huge difference. Patients with normal perfusion and normal blood flow makes a huge difference for them, because you can rule out coronary artery disease. They're at a very low risk. Patients with normal perfusion but abnormal blood flow reserve, these are patients that would need further evaluation and are most likely have microvascular disease. Determine the success of, or also people with normal looking perfusion but abnormal blood flow may also have multivessel disease or global ischemia. So those are the patients that should go to the cath lab. Determine the success of vasodilation. If it's less than 1.2 with no obvious perfusion abnormalities, then those patients are most likely to be non-responders, meaning they did not vasodilate, and you essentially have two resting scans in front of you. Those patients should be repeated, and you could do blood work to make sure they haven't had caffeine, or make sure that they abstain from it longer. Some patients who are non-responders, it sometimes benefits for the lab to withhold caffeine on those patients for 48 or 72 hours and then repeat the study. If you have equivocal perfusion, does blood flow really help? It does, because if you're not sure on the perfusion and your blood flow is normal, then you can side on the side of normal perfusion, normal blood flow. If you are on the fence about perfusion and the blood flow is abnormal, then it falls into that category, that second bullet point there, where they probably either have microvascular disease or multivessel disease. And it will help you figure out if you're missing high risk coronary artery disease. And then lastly, the myocardial blood flow reserve makes a huge difference clinically for management of patients, because that identification of microvascular disease is extremely important. This is an example of a study that is completely normal. You have the normal perfusion, stress on top, rest on bottom, short axis, vertical long and horizontal long there on the left side of the image. and or on the left side. So you see that it's perfectly normal. There's no perfusion defects anywhere. I do want to point out here that the apex looks a little thinner, and that's perfectly normal. You see that on PET because that happens normally with aging, and PET has better spatial resolution. So we see it on PET and we don't see it on SPECT, but it's normal. And then if you go over to the blood flow reserve numbers, the resting is all less than 1, the stress is all greater than 2, and the overall reserve is greater than 3 across the board. It just needs to be greater than 2. So that's fantastic. That's a normal blood flow reserve. You also can look at the polar maps and see that there's no areas of ischemia. It looks pretty perfused everywhere. And I want to point out that there's a little box here. If on your processing software you select that box, that will overlay the 17 segment map on top of it. So if somebody does have reduced blood flow reserve, you can correlate that or identify it, compare it to the 17 segment model to better locate the area. And then, so a patient like this that is normal perfusion, normal blood flow, has a negative predictive value of 98%. So that means there's a 2% or less chance of that person having any coronary artery disease or cardiac events in the next 5 years. This is a 55-year-old patient with chest pain, normal perfusion, abnormal myocardial blood flow reserve, and this patient had triple vessel disease seen on their cath study. So you can look at this and see that their perfusion is pretty normal. You do see here in the septal wall, but that's the connection of the right ventricle. So that's a normal finding there. But images on the perfusion look normal. You go over to the blood flow here, and the stress blood flow reserve numbers are reduced across the board. Even though their time activity curve looks good, they had a good bolus, good arrival of the radiopharmaceutical with accumulation in the myocardium. When you go to the reserve, all these numbers are really low. They're in the high risk category because they're just barely above 1.2. And so this patient, normal perfusion, markedly abnormal blood flow. This is one of those patients that would be of concern for multi-vessel disease or global ischemia. And then when this patient went to cath, they did confirm that because triple vessel disease was seen on their cath. So before myocardial blood flow, normal perfusion did not exclude coronary artery disease, especially balanced ischemia, which is what we saw on that last slide. After myocardial blood flow, most patients that have a normal perfusion and normal blood flow have a very high negative predictive value of having any heart disease. But when you have a normal perfusion and abnormal blood flow, it could be a number of things. It could be balanced coronary artery disease, which we saw in the last slide, microvascular disease, or it could be both. And it's really important when there's to note that a normal cath does not exclude microvascular disease because that cath cannot get into the smaller blood vessels to evaluate those. It cannot detect microvascular disease at all. So this really helps physicians to determine to cath or not cath. If it's mildly abnormal, it's more likely microvascular disease. If they have a low calcium score along with it, then it's even more likely to be microvascular disease. And this does relate only to patients with no known coronary artery disease. If they have known coronary artery disease, they have a cardiac history, then you can expect that those blood flow reserves might be abnormal, or they might have developed enough collateral circulation that the blood flow is appearing normal, even if the perfusion slightly isn't. So they don't always match up, but it is extremely valuable in patients who do not have a history or known history of coronary artery disease. Now, in relation to calcium scoring with it, or even just the evaluation of calcium on the PET perfusion images, normal perfusion and abnormal blood flow will have a mild to moderate reduction in the blood flow, and this is more often due to microvascular disease. A lower reduction of 1.2 to 1.7 is more likely due to epicardial disease. So epicardial, remember, is the ones that we're used to looking at, the LAD, left circumflex, and right coronary artery. When you have a calcium score with it and epicardial coronary artery disease, a high calcium score means that there is epicardial disease. A low calcium score often indicates microvascular disease. So it's always a good idea to evaluate calcium, even if it's a non-diagnostic CT just being used for attenuation correction. It will still show the calcium. Now, I do want to caution, because it's a non-diagnostic study, it should not be done to calculate a calcium score. Your CEDARs and your 4DM, they will have software in there that will give you a calcium score, but it's not accurate when it's a non-diagnostic study. So don't look at the actual calcium score when it's attenuation correction CT, but you can still evaluate those images for the presence of calcium, and it's still going to correlate very similarly. Mild reduction in myocardial blood flow reserve and low or no calcium more likely is the result of microvascular disease. So this is an example of normal perfusion, abnormal blood flow reserve, and then the patient had that triple vessel disease on their cath. So these are the pictures here on the left. You see that there's normal perfusion. You see down here in the bottom left corner where they placed that cursor on the left atrium for the blood flow reserve, and then you can see their graph there, their time activity curve looks really good. And then you go over to their blood flow reserve numbers, and you'll see that there is a global decrease in the myocardial blood flow reserve. Left circumflex looks a little worse than everything else, but their global blood flow reserve is 1.6, which is less than the 1.7. It falls right in that 1.2 to 1.7 category. So this patient got a heart cath, and it was determined that they had triple vessel disease. This is another example. This has normal perfusion and then globally decreased reserve. The reserve numbers are down here on the bottom left. And you see that the total reserve is 1.6. And then if you look at the reserve numbers, it's 1.7 to 2 for the LAD and right coronary, which carries an intermediate risk, but the left circumflex is 1.3. And then if you actually look at the polar map, it pulls that out for you and tells you that area of ischemia that it kind of, or the area where it's the least, is about 1.6. So it tells you that it does correlate to a little bit of a defect there. And then if you look at the presence of calcium, you will see that there is also calcium in that area. So this is normal perfusion, abnormal blood flow. And this patient had a bypass. If you look at the images here, the perfusion looks pretty normal. This is an example of balanced ischemia again, because if you look at the reserve numbers, they're pretty low. And right coronary is only 1.2, globally is only 1.37. So this person had a very high risk. The doctor determined that the heart cath was not necessary, and the patient went straight to getting a bypass. If you look at, this is an example where that 17 segment model is overlapped on it, and you can actually see the areas of greatest reserve issues, and it is pretty globally. I was gonna say it looks a little bit more at the base, but not really when you kind of look, the apex is 1.42. So this patient ended up getting a bypass that was much needed. And I want to point out, if just perfusion is done, then this is all that we have to go by, and the images would be read as normal. But because the blood flow was done, that patient who needed a cath was able to get one. And this is one of the greatest benefits of doing cardiac PET and being able to assess for myocardial blood flow reserve, is you're catching more of those patients that would be false negatives, and you're able to get them that intervention that they need. All right, so this one has the answer on it, but what about this one? I want you guys to kind of look at it first. So the perfusion looks okay, but if you go to the blood flow reserve numbers, one of them is a little bit low. The I'm sorry, the global reserve is really low. The LAD is only 1, and the globally is only 1.2. So you would look at that with normal perfusion and think maybe the patient needs a bypass. But this is where I said the first thing you need to do if you see this is go back and look at the resting. This person has really high resting numbers. The LAD is 3.06 for their resting. That should be less than 1. The RCA is 2. That should be less than 1. And so if you look at this, it's greatly affecting it. But then if you go now and look at this time activity curve, this is one of those instances where the bolus arrived and then it kind of stayed. It doesn't ever go through the left ventricle. And what happens with this is that blood flow fails QC and it should not be reported. That's why you look at the time activity curve. And so this is one that just failed. It's not a technically good study for the blood flow reserve, even though the perfusion might be okay. So the best thing to do in that case would be to repeat that study on that patient if there's suspicion of coronary artery disease. So this is an example of an abnormal myocardial blood flow reserve due to really high resting values. Perfusion looks normal. And then you go down to the reserve numbers. The reserve is globally decreased, but it's also decreased in almost every vessel. And then you go to the resting numbers, and you see that the resting numbers are elevated. They're all above 1. So this is an example where it's not a technically good study. It's not going to pass the QC. And so you can still read the perfusion, or the doctor can still read the perfusion and say what they see and determine what to do with the patient. But the blood flow reserve portion could be considered non-diagnostic. There are some clinical situations where myocardial blood flow reserve makes a big difference. This is where, like I said, normal perfusion, abnormal, we discussed all those. Now, if they have equivocal perfusion, does the blood flow help? That's the next thing that we're going to talk about. So this is one that has abnormal perfusion, and the question is this due to motion, or is this coronary artery disease? It can be very difficult to identify motion on the PET and PI studies. And so the myocardial blood flow reserve can help determine whether something is coronary artery disease or motion. And so in this patient, you see that it's a little bit equivocal here in the septal wall and maybe anterior. It looks like maybe there's something there. You even see kind of a spot down here. But if you look at the myocardial blood flow reserve numbers, they look okay, and the chart looks okay. So the normal blood flow favors that this is a motion artifact. And remember, motion artifacts are often contralateral, so it almost will look like a cross or bullseye. And here you see it like top to bottom, and the heart appears a little bit more egg-shaped than round on the short axis. That also indicates that it may be motion. So because the blood flow reserve numbers are normal, then you can confidently, doctor can confidently say that that is a normal study. So this is another one where if you look at the images here in the short axis on the stress, it kind of looks like there's a defect in the inferior lateral wall. And that's a common location for motion to create an artifact, and you see it on several slices. So it's kind of questionable, but if you go to the reserve looks normal. And so this is a motion artifact with normal blood flow. So myocardial perfusion or myocardial blood flow reserve adds value in multiple ways to patients with abnormal perfusion. It assists the doctors in being able to confirm whether it's abnormal with small defects or consider a normal with an artifact. Single vessel perfusion defect, a single vessel myocardial blood flow reserve confirms the likelihood that it is single vessel coronary artery disease. 2 or 3 vessels suggest more advanced coronary artery disease. And then if it's single vessel perfusion, 3 vessel myocardial blood flow could also indicate a combination of coronary artery disease and microvascular disease. So it gives a lot of information for the doctors to work with. And if there's a single vessel perfusion defect but normal regional blood flow, that's where you need to look at the individual segments, or the physician does, to determine if it's single vessel disease or not. This is an example of an abnormal study. You see that there is decreased perfusion down here in the inferior wall and even in the septal wall. And then if you go to the vertical long axis, you see that there is decrease from the apex all across the inferior wall. So this is an abnormal perfusion. When you look at the blood flow in the same patient, the blood flow globally is at a 2, which is great, but the RCA is at 1.7, and none of the resting is high. The time activity curve looks good, but the stress is low on the RCA. And so that's what's causing that one to be lower than what it should be. So this patient was taken to heart cath, and these are the enlarged polar maps with the blood flow reserve, and the 17 segment map is turned on. You can see here in the 17 segment map that regionally it does correlate with ischemia that you're seeing on the perfusion study. You see that in the inferior wall from apex to base, it does have decreased myocardial blood flow reserve, and even in the apex a little bit, it's 1.8. So single vessel disease in the right coronary artery was the diagnosis for that patient. Now, this patient has abnormal perfusion with no increase in myocardial blood flow reserve. This is a patient that is very high risk for coronary artery disease. If you look at the perfusion on the short axis, you see inferior lateral defect, and you also see a lot of thinning. I would guess just by looking at it that this patient probably had a high TID ratio also. But again, this blood flow is a better assessment of that. And then if you look at the vertical long axis, you even see that inferior and apical, there's decreased perfusion, but the entire heart appears thinner on stress than it did on rest. If you look at the total blood flow reserve numbers, it is 1.1 globally. You look at all of them, all the uh, all the epicardial vessels, and you see that it is decreased everywhere. You look at the derived and defect polar maps, and you can see that it does look like this patient has some global ischemia. So this person falls in that category of being less than 1.2 with a perfusion defect. This is a highly abnormal study. This patient has a very high risk of coronary artery disease. Then the last thing that I want to talk to you guys about is splenic shutoff. And this is something that's relatively new with cardiac PET. It doesn't have a real hard set rule on normal versus abnormal values. There's not a big consensus in our field, but one of the things that you can see with patients to determine whether or not they responded to vasodilation is if they have a splenic shutoff. And so basically the spleen always appears a little bit hot on rubidium studies, but if it will always show up higher on the rest. So the image up here in A is their rest, and in B is their stress. But when they have the presence of vasodilator, it dilates the blood vessels of their heart, and it kind of shuts off the rubidium going to the spleen. More of it will get taken up by the heart. The blood vessels in the heart are dilated. There's more blood flow there. So you do not see the rubidium so much in the spleen. And there is a math formula here to help figure that out. But a lot of times it's just visually noted whether or not the spleen has additional perfusion and rubidium in it or not. And it will either be the same as resting or more if they are a non-responder, or if they did respond to vasodilation, it will be less. So this is an example of splenic shutoff. This is somebody that did respond to the vasodilator, and you see that the spleen did shut off. That's kind of what they call it, is splenic shutoff. It's not as perfused at stress as it was at rest. So this is an example where that can be a valuable tool. If you look at A right here at the top of the image and you see the perfusion images, it looks like fairly normal perfusion. There's some apical thinning, but other than that, it looks like a fairly normal study. And then you go to the reserve numbers. The total reserve is 1.09. And globally, it looks like it's decreased. And then evaluation of the spleen, it looks like they did not respond. And that concludes this presentation on myocardial blood flow reserve. I hope you enjoyed. Thank you for watching.